Good evening. Buenas noches. Thank you for joining us tonight. On behalf of Mitchell Kaplan, the Miami Book Fair, and all of us at Books and Books, I'm honored to welcome you to tonight's virtual evening with Michele Harper to discuss her stunning new memoir, The Beauty in Breaking, published by Riverhead Books. The Beauty in Breaking reveals Michele's healing process following the end of a marriage and the beginning of a new life in a new city and at a new job in a central Philadelphia hospital. From her position as an emergency room physician, brimming with vignettes of patient care, Michele shares valuable lessons of regeneration and recovery as a daughter, woman, and doctor. A New York Times bestseller, The Beauty in Breaking has been featured on Fresh Air, The Daily Show with Trevor Noah, NBC Nightly News, MSNBC, Weekend Edition, and more. And the New York Times Book Review celebrated it as riveting, heartbreaking, sometimes difficult, always inspiring. Michele Harper is an African-American emergency room physician in a profession that is overwhelmingly male and white. She has worked as an emergency room doctor for more than a decade at various institutions, including as chief resident at Lincoln Hospital in the South Bronx and in the emergency department at the Veterans Affairs Medical Center in Philadelphia. She's a graduate of Harvard University and the Renaissance School of Medicine at Stony Brook University, and The Beauty in Breaking is her first book. Michele, will you hold it up for us, please? There we go. So Michele is joined in conversation tonight by Daniela Lamas, the author of You Can Stop Humming Now, A Doctor's Story of Life, Death, and the In-Between, a collection of stories focusing on the experiences of patients kept alive by modern medical technology. Daniela had her book launch at Books and Books in Coral Gables a few years ago, and we thank her for joining us tonight. She's a pulmonary and critical care doctor at the Brigham and Women's Hospital and faculty at the Harvard Medical School. Following graduation from Harvard College, she went on to earn her MD at Columbia University College, where she also completed an internship and residency. She then returned to Boston for her subspecialty fellowship. She's worked as a medical reporter at the Miami Herald and is frequently published in the New York Times. Throughout this evening's broadcast, we invite you to ask questions by pressing the Ask a Question button at the bottom of the screen. And you can find The Beauty in Breaking for purchase at Books and Books below by clicking the green button. Every purchase you make helps support Books and Books during these uncertain times. And now, without further ado, I welcome Michele and Daniela to the stage.
Thank you. So I figured I'd briefly read from the introduction just to get us started. As I cradled my patient's head in my hands, I looked past the watery wells of his eyes. For a moment, I didn't notice the blood that ran in rivulets across my gloves as it poured from his scalp, or the bits of gray and white brain matter that dotted the sheets. The beeping of the monitors around me, the popping sound of IV catheter tops being flicked off by the nurses, the screeching of wheels as equipment was dragged across linoleum floors, the nurses and techs yelling directions at one another, the stifled gasps erupting from the two medical students on their first ER shift, attempting in vain not to be startled. All were drowned out as I stood over this young man and tried to ease his agitation. This is the part of being a doctor that medical school doesn't cover, that case reviews don't prepare you for. This is the part you can't really know until you're in the moment. You are the person responsible for saving the human life that slowly slips through your fingers while silently begging for final redemption under the demanding fluorescent lights. I am the doctor whose palm bolster the head of the 20-year-old man with a gunshot wound to his brain. I support the baby as she takes her first breath outside her mother's womb. I hug the wife whose husband is dying from advanced liver disease as she implores the universe to take away his pain. I claim no special powers, nor do I know how to handle death any better than you. What I know is that for 36 hours a week, I reside in the melee that is a hospital emergency room, where I'm called upon to be salved, antidote, and sometimes Charon. Most of the time, my job is to keep death at bay. When I am successful, I send the patient back out into the world. When I'm not, I am there as life passes away. I'm not so deluded as to think that I alone am capable of making that kind of difference. I'm well aware that the determination of who lives and who dies doesn't happen at my hands alone. There are times when, despite the designs of any patient, family member, friend, or doctor, death will come. Then I am witness. What I can do is be the fairy woman who holds the body as the last breath escapes, the one who, like the night sentinel, calls out the hour and does her best to convey that all is well. Like everyone, I am in the world for only a brief time, and as for many, blessings abound in my life, and they abound amid the struggle, amid my struggle. Over the decades, I've learned to cultivate a personal state of stillness. As a child, that stillness grew from a dissociation I stumbled upon that allowed me to better endure life with a father who was a batterer and with a family legacy of victimhood. As a Black woman, I navigate an American landscape that claims to be post racial when every waking moment reveals the contrary. An American landscape that requires all women to pound tenaciously against the proverbial glass ceiling, which we've since discovered is made of palladium, the kind of glass that would sooner bow than shatter. When I began writing this book, I had started over. My marriage to my college sweetheart had ended. I had moved to a new city to start a new job. Plagued with doubt, I found myself having to reevaluate my life. Living through such changes was difficult. Now I see those junctures, when everything I had counted on came to an abrupt end, as a privilege. They gave me the opportunity to be uncertain, and in that uncertainty grew opportunity.
So those are beautiful words, and hearing them from in your voice is so particularly powerful. So thank you for that. It's so interesting to me always when you read a book and then you actually hear the author read it and see them. There's a definitely a unique sort of power in learning to that. And so as you were speaking and telling us about this moment of uncertainty, it's so hard not to see that, to hear that within the framework of where we are all right now, in this huge degree of uncertainty, where we are all forced to take that pause and say, where am I, and where do we go from here? And it is impossible not to read your whole book through the lens of where we are now in the midst of a devastating ongoing pandemic that has made clear these huge inequities that clearly have existed far before this pandemic. You write about them. And so I'm just wondering if you could tell us a little bit about kind of where you are now in the hospital in your work, and what is it like kind of replaying these stories? What is it like even reading those words aloud to us now, sort of knowing where we are in our healthcare system and in our broader country?
Right. It is interesting because I wrote it even years before this pandemic started or any of us had notion that it would happen. And what's interesting is that the reason I wrote it still rings true. It's highlighted to me the importance of communication and listening and our interconnectedness. And it lays bare the issues in our healthcare system that have always been there, but are just harder to ignore. I think about recently, I saw a patient who, of course, we both had masks on, and she was an older woman, like 60s, coming in with history of a headache for a decade, but actually right now she had no symptoms at all, but she was coming in anyway. And she kept asking me the same questions over and over again. And I told her I'd reviewed her records. There was a minor brain tumor. It sounds scary, but in the records it was minor. And she was told to follow up because she was getting headaches. She was totally asymptomatic. Her exam was normal, and she just kept asking the same questions, but she wasn't confused. And I was using a translator phone because she didn't speak English and I don't speak Creole. And I was getting frustrated. And I almost left the room because I didn't have time to keep answering the same question over and over again. But I kept asking, well, do you have any more questions? Even though it was the same question. And so we were almost done. And I asked one more time, any more questions? And then all of a sudden I saw a tear roll down her face. And I realized in that moment that there was more to it. She was scared, and I couldn't pick up the cue because I could only see a strip of her face. And she couldn't pick up cues from me because she couldn't see my eyes either. And we were just doing the best we could with the translator phone. And that's when I said to the translator, can you please tell her it looks like she's upset? And can you ask her why she's upset? And the reason she came in and was perseverating on the question and was upset was she didn't have health care and she didn't know what to do to follow up. And she remembers she was told to follow up. So I'm reminded of the importance of our listening as healthcare providers and humans, and that there's often so much more to the story that we can get to if we're willing to be there and be present. I'm also reminded of the fact that this is an instance again where we're in a time of pandemic where people don't know where to go for care. And also there are disparities. This woman can't even access care. Now, we addressed it. I got her plugged into charity care and the clinic. So hopefully it will work out. But again, lays bare these issues that are becoming impossible for us to ignore, thank God, so that we can work on these inequities and fix them.
Yeah, I mean that's a great image. Like just to think of this woman who, in a time when people are still avoiding hospitals if they possibly can, like this was the place where she felt she had to go because she was so scared. That's profound, and that distance that the mask brings. I mean, in a lot of your stories, there's the plus one there, right? The family member at the bedside. As you were telling that story, it sounded like she was alone, and maybe she's alone in her life. Clearly, she was alone in the ER. What is it like right now? And this is something I've been interested in the ICU. What is it like right now in the ER? Perhaps without families, maybe you're allowing them back in. I'm not sure what the policy is at your hospital.
We're not, and so she was alone, and usually it was one of her children who would help her navigate the system and navigate care, and also just help with communication.
Right.
So it did add to the lost in translation element. Not only was no masks, but no family, no support, no collateral information. So it's made it more challenging.
It's so isolating. And for a doctor who, it sounds like you have found ways within the sort of infrastructure and the time crunch of the ER to make these connections with patients. It must be hard. I mean, it's hard. Right. Which I guess gets me to the question about sort of what brought you to this world to begin with. And all doctors have stories about what brought us to medicine. And I should just say to everybody listening, we're going to chat for about 20, 25 minutes or so. But we'd love to get everybody's questions, as Christina mentioned. So just put them in the question box, and within the limitations of our own technological know-how, we will retrieve them and chat about them. So I just, I obviously found the story that you told about what brought you to emergency medicine in this book to be particularly powerful. And so I was wondering if you could share a little bit about that, and also how the realities of medicine, of a lot of these inequities that we've already brought up, how that kind of compares to what initially drew you to this world and kind of your hopes for
it. So I say how, as a child growing up in a unsafe environment with a father as a batterer, I feel that in many ways that groomed me to be an ER physician. In the ER, it's just, you get a snapshot in time and you have to decide in the moment, is this immediately life-threatening? Is it maybe something we can manage and monitor because it won't kill anyone right now? Or is it just gonna blow over? So I had to hone those skills as a child. And they directly translate to my work as an ER doctor. And it's stayed with me that and it could have been any day, but there are various instances that shocked me to my core. Like when I was a teenager and my brother was restraining my father in an effort to protect all of us, and specifically my mother. And my father bit my brother's hand, and hard, and it needed care and medical attention. And it was so traumatic because I thought, if somebody could do that, if your family member could do that to another family, then there is no safety. There's no safety. That's the person who's supposed to take care of you, who's supposed to raise you, be your security. but that was lacking. And then contrast that to when I took my brother to the emergency department and I saw this place where all types of people converge looking for something, some kind of healing, salvation, redemption, whether it's the homeless man who just needs moments outside of the elements to rest, or a little girl who was cut, or somebody who's coding and dying, where EMS workers are doing chest compressions, and the family are the ones who are looking for answers, looking for care. All of those people can meet there, and many of them, like the little girl, skip out, healed and helped. That homeless man, well, at least he got a couple minutes of rest before he too will have to go out. And so it was a reminder to me in a concrete way that there's another side. Like, as long as I can make it through this, that I not only can be healed as well, but I can be part of the support systems for others who are looking or choosing healing.
Sir left me with many, many powerful images, and that idea of that triage of what is immediately life-threatening, what can you let go, and what do you say, oh, this is going to be okay, in a world where a child is forced to deal with that.
I'm sorry. There was another part of your question, like,
tell me.
What is it?
Oh yeah. No, I got distracted by my question. So now, well, here, wait. Let me ask. I wanted to follow up on something, and then we'll get to it. So you're painting the image. You know, you're in the ER, and your brother was just bitten by your father when he was trying to protect your mother, which is obviously like deeply, deeply devastating. And you're there. Do you wonder whether any of the doctors at that point, you had this intersection with the healthcare system, you had this intersection with these people. Do you wonder about them, about their trying to find out more about what could have set that story off differently as they intersected with a boy who had been abused? So how did that kind of play into your thoughts, I guess, now?
And in retrospect, it does. I mean, at the time when I was going through high school or going to my annual physical, seeing my pediatrician, there were so many steps along the way that no one asked. And of course, at the time I was young and just in survival mode, and plus young people, they don't have the language or the capacity to understand. But in retrospect, now that I'm an adult and a physician and a mandated reporter who actively screens all the time, it's heartbreaking to think that no one ever asked. No one ever asked me. I don't know specifically because there's so much silence. So I don't know if they screened sister or brother because we didn't talk about it. But it is disturbing. And that's one of the reasons it was so important for me to be open about this, because I'm hoping that in my being open, it breaks the shame around it. And also it's a reminder to those of us who are, well, all of us, those of us who are specifically in helping fields, but also just in our personal lives, to care and look and listen, ask and act.
Yeah, I think that's powerful. And I didn't think about that when I initially read your book, and I was just thinking about it when you tell that story now, and thinking about, oh, there are these moments. And and as a physician, that's frightening, right? To say, like, you intersect with these people and in these moments of climax, and you don't know what's behind there and what do you miss. And it gets to that initial premise, what's immediately life-threatening, and what can you set aside? And like this was something that and what's hidden. And I'm wondering, like, do you find in your work now, I mean, you probably have a higher index of suspicion. Does that ever get you, do you ever find that, I mean, it's beneficial in some of your stories, and if you want to tell us about that, but does it paralyze you at all ever? Like, do you feel like you're looking too much into stories to find something that might not be there? I don't know.
That's interesting. I suppose it's just part of our work to ask and screen and keep moving. So in some ways we're practiced at that. We ask the question. Truthfully, there are times we may not believe the answer, but in those cases, we can't keep digging. I mean, that would be awkward, probably inappropriate, but we at least we at least address it. But then part of the job is just to keep it moving. So in that way, it doesn't become overwhelming. But when the information comes out, it can be really difficult. I mean, like in recent history, so after the book, I had another teenager, young teenager, brought in by her mother for exacerbation of her chronic anxiety, but not suicidal, not depressed. She could cope. They just couldn't. The office was closed to reach their doctor for a referral, so they came to the ER. Not just maybe we had a referral for her. That was really it. And that was one of those moments I definitely could have just let it go. Because they got along well. They both seemed like lovely, this patient and her mother. But I asked to speak to the girl alone, as I often do, where I want to do certain screenings. And then I told the mom, of course, she could come back in. And the girl said that she had been depressed for many years. And it all started when her aunt sexually abused her. Her aunt, who was actually out of state, and I believe it was a different country. So she wasn't around her, she was safe. But that's when it started. And she said she had disclosed this to her mother. And her mother had said she didn't believe it. She was close with her sister and made it clear to her she never wanted her to bring it up again. So this is what she was struggling with. And so I had asked her, I was like, certain topics I do need to speak to other people about. This is one of them. So I asked her if I had permission to bring her mother back in and speak with her about it with her. And she said, please do, because maybe if she hears it from a doctor, she'll believe me.
Wow.
And to this day, I mean, I'm glad we did. And, we began the process, and the girl was she was relieved that someone validated what she felt and wanted to help her. I mean, the mother was receptive and fell apart in the room and was apologetic. And it's just an example of where it was important to probe. And I believe it was helpful in bringing them to this crossroads where they could heal.
Yeah, I mean, you opened that door, it sounds like, and it probably, I mean, it's obviously what the daughter wanted, but like it wouldn't have happened if you didn't open that door, which is really powerful. And so, I think that's something that you tell us in a lot of the stories in your book, is that there are places where you open the door and you learn about patients, and maybe not about just the solitary complaint that brought them in, but why that brought them in. But you're an emergency medicine physician, and the which I say in a positive way, but that's hard. Like your job is also to move. I think, at least that's my experience of emergency medicine. How do you balance this connection and also becoming emotionally invested? When too much emotional investment, one cannot take on all of the emotions of all the people you see in the day. You collapse. How do you personally manage that, either now in COVID or and how has maybe that shifted over your career? Because I think those things shift.
So, for the first part of the question, you are totally right. We have to move, and it gets busy and crazy. And you could have a patient with a stroke in one room, a heart attack in another, someone who was stabbed down the hallway. So you're right. And when I think of triage, like categorizing what's most important, where to go at any given point in time, I do factor in these other issues that might not be on the surface. For example, a Black patient who was brought in police custody, and there was a lot of commotion when he was brought in, and I heard people telling him he had to agree with an exam. And so apparently the police said that he had swallowed drugs, and they were saying they had to be removed, and the staff had to do it, even though he didn't want to be evaluated or examined or treated in any way. So I got involved in that situation. I was the doctor in charge. He was a Black patient. I was the only Black healthcare provider, like nurse or doctor in that whole section. I was the doctor in charge. So the patient was fine medically, not intoxicated, competent. So the law is you cannot force an exam on someone who is competent. And I explained that to the police and to the staff. And then my resident, this white female resident, felt that I shouldn't be able to make such a decision and called hospital ethics and legal to try and go around me for that. And then hospital ethics and legal then proceeded to tell her that actually I am correct and that is the law. And so he will be discharged, like I said. And that's what I did. And that was an example where not only was it deemed that he didn't have the right to personal sovereignty, but it was also deemed that I didn't have authority either. So in that situation, I intervened because it was critically important, like as important as any heart attack or stroke.
Yeah.
It was important for me to protect this man's right and to address the structural racism, not only within the police department, but also within our own house in medicine. So that's why, to the extent that it's possible, I triage these cases very highly, like whether it's that or the little girl who might have been abused. So that's the first part. And then the second part, you're right, it's hard, like personally, emotionally, spiritually. And I guess that gets into my own self-care. That's really the buzzword, self-care practices. And what resonates with me is the physical practice of yoga is very important for me. Actually, when this is over, I'm going to go do yoga.
And do you do this in your apartment now?
Now I do. Yeah, this is post-pandemic, like on my computer, safe.
So you have a good video, so good.
Yeah, physical practice or meditation. Listen to spiritual leaders like Eckhart Tolle on my commute to work. Like the one benefit of my long commute to work is I listen to Eckhart Tolle. So those are some of my own practices, because you are right. I mean, otherwise it wouldn't be sustainable.
Yeah, I mean, I guess that's part of the triage, is knowing what is sustainable for yourself too. But I love the idea of triage, because when people use that word, we think about where is the blood gushing the most, and it's that, but there's also things that we can't see and that need to be triaged too. And I guess that's a way to keep yourself sane to some degree. Is yes, every family, when families were around. Every family doesn't need the hour-long family meeting, but there's some triage to that. And that makes sense. It's good. It's really good to think about. When we're talking about patients, so many books that we have of doctor stories have these portraits of doctors who are infinitely sympathetic and have the loveliest patients. They all just seem like remarkably wonderful people, and everybody has benefits, and there are people, there's some grace and interest in every individual. But I think I loved one chapter particularly, as I had told you about Eric, the idea that you decided to tell a story about an unsympathetic patient where you were very human in that moment. You didn't come in and say initially, every patient is a lovely person, and so I'm going to spend a lot of time with this gentleman who has this like safety alert attached to him. So I'd love it if you could tell us a little bit about Eric, and also just why you chose to tell this story about being human in front of an unsympathetic patient.
Right. Yeah, I did include a couple unsympathetic patients. So
you did.
Eric in particular signed in, and his initial paperwork that was completed by the nurse initially said he was signing in for a hemorrhoid. When I pulled up his chart, there was an alert, because at this place I was working, they had this one institution where if they were violent, for example, against a staff member, they would put a note in the chart so people were aware and for safety precautions. And this patient had an alert that on a previous visit, when a female doctor was treating him for an abscess and cutting it open to treat it, he sexually assaulted her during this treatment. And it explained how, she put down her knife, left, and then casually said, so the procedure was completed by someone else. And I was a little horrified the way it was described as so commonplace, and horrified by his behavior as well. It wasn't clear by any of the documentation that he was held accountable, that the institution did anything about it. And now here he was again. So I looked at his initial triage when he was coming in. His vital signs were fine. It was a hemorrhoid. So I figured I could go get coffee. He could wait a couple minutes for me to get coffee. That's the least that he could do. And so I made my coffee, poured in the sugar, like grain by grain, and then the creamer, poured it up, tasted it, went back. And then I saw him because I was like, you know what? Maybe he could wait. But at any moment, other people could come in and they shouldn't wait. So I'm going to see him so that other people don't have to wait. That was my mentality. And so when I got there, the nurse and I both felt the same. And he was writhing around in the stretcher. He looked very uncomfortable. And I thought, well, that's a bit much for a hemorrhoid, but you never know. But it turns out it actually wasn't a hemorrhoid at all. It was an incarcerated hernia. But in lay people's terms, it was a condition that he needed to get operated on to be better, so he wouldn't get an overwhelming infection or die. So in the moment when I examined him and saw that this was something very different and had nothing to do, not even anatomically, with a hemorrhoid, I did think back to how, maybe it was even just 2 minutes for me to get coffee, but how my assessment of his past behavior and the misinformation from Triage, how I took both of those on and made this man wait. Now, it's very, very true. His behavior was heinous, and he might be heinous. That's not the point. And yes, it's true he needs to be held accountable. And yes, it's true the institution needs to be held accountable. And it's also true that I should have brought none of that into the room and should have just treated him physically, and also realizing that I don't actually know who he is now. And so whatever shred of humanity there is there, I need to connect to and do right by him, because it has little to do with him and everything to do with me and how I am in this world and how I live in this world. And so that's why I told the story, because it is easy to fall into that trap that we're going to do the right thing for people because people are good. Well, people aren't always good, but we still need to do the right thing. And I think that is the only way that will not only that, I would heal personally, but also that may be his only path to healing, society's path to healing. Interestingly, that day, all the doctors involved in his care were women. Did he think about that? Was it the people to hold a space for him, to literally take care of him, to save his life, were all women? Maybe that was his opportunity. So that's why I tell stories like that also.
Yeah. I think that's a great story. And I hope that I hope that a lot of medicine trainees read that as well, because there is such shame, I think, in not being this sort of angelic creature who walks through the hospital and sees the goodness in everybody. And it's like, this is my calling. It never feels like a job. It's always where I want to be. And acknowledging that that's not always true, because this system is terrible. And some humans, as you say, are terrible. Also, they get sick.
Right.
Right. And that's a hard thing to hold.
No matter what I'm going to do, I can't. And I also specifically didn't do it hoping that he would be a better person. I mean, I really don't, whether or not he's a better person, I could care less. It has nothing to do with my life, but it was the right thing to do. And it opens the door of potential.
Yeah. And you made it a possibility, maybe. And at least you didn't hurt him. And he got care. He got care, which he deserved. So yeah, I thought that was really kind of interesting. That story and so many other stories have me wondering, sort of how you chose each of these stories in this book to put together this whole, sort of how you think about that kind of arc, and then also to what extent how you navigate confidentiality and how you feel about creating these stories. I know everybody does it differently, and I'm wondering kind of how your process came to be, and maybe that changed over time too.
Well, in this book, I did backflips. Probably even more so than was necessary, because part of it was my naivete. I thought, once it's under contract, in 60 days, this book is going to be out. That's not even close to true. So I didn't realize that then, a couple of years would go by. So So time is protective also, like the further away
Yes.
we in these cases. And I've worked in a number of institutions. So time alone makes it harder to identify who was where, because we see thousands of patients a year. Okay. So, but in addition to time and the fact that I've worked many places, of course, they're all pseudonyms apart from first degree relatives, because and my ex-husband, I mean, it's discoverable. There's only one Philadelphia VA. So other than that, I changed the names of locations, patients, colleagues. There were a couple patients I even changed their gender, because I thought at the time, the case was so identifiable that I changed their gender. One case location, I moved. So I took many steps for confidentiality in that way. The only thing I would say now in retrospect is probably some of that was above and beyond, but it's still a concern. Like as I write essays, like an essay application from last year, for example, I'm careful about that. And I don't say the location of the hospital. And of course I change any relevant names, because it is important to protect that.
It is, but it for me always raises this question of like, what is the line between like medical, because of the HIPAA stuff, narrative, nonfiction, and fiction, and there's always the nugget of truth that you're telling, but it's an interesting. There are not that many other worlds where you say, okay, you need to change all these details, but then also call it nonfiction. I don't know if you have any sort of thoughts on that line between fiction and non.
I don't know. I guess I personally am fine with it, only because of, well, a couple things. Because of the nature of the work we do, it's important. And I do feel a little more protection since I'm emergency medicine and I see so many patients.
That's true.
That it makes it a little easier, and I don't have regular patients. I honestly don't know how I would navigate it if I was a primary care provider and had regular patients. I don't know how it would be possible, honestly. I think that being an ER doctor makes it easier in that way. But then the line, I feel like if the story is true, then the detail of form, meaning the name has changed, or the person is a woman instead of a man. Now, mind you, I didn't change it. If the case I changed it, the gender didn't matter at all.
Gotcha.
Then I feel like it's still real. It's not fiction. It's just a change of a non-essential detail to protect confidentiality, since I'm a doctor.
I think that totally makes sense. There's a psychiatrist who wrote this like great essay in the Times Opinion maybe 8 years ago about how he was writing about his patients, and so he felt uncomfortable about that, right, as a psychiatrist, as one should. And so he changed all of these details and inadvertently changed it such that an entirely different patient called him up and said, "You're writing about me." He's like, "Well, actually, I was writing about a different patient." But so you can just get into these traps, I guess.
Right. That is funny. No, and it's like whenever these, I don't know, I guess if you have a major publisher, you work with the publisher, everybody's clear on like what was changed. That is funny though. I did think to myself, what if certain people call me and say that's about me? I mean, especially with the case I write about, I have a very good memory. Actually, I had one of my colleagues who read the book say, "I took care of that patient." And then she proceeded to tell me about the patient. I was like, that's not at all who I was writing about. It's just not at all. But your patient sounds cool too.
Yeah, because people bring their whole own like, "Oh, is this about me? I remember this thing," and like they bring their whole own story to it, which is kind of interesting. So there's some questions accumulating here in the chat box, but I'll ask one more question first, which is, some people write, not, I was going to say just, but that sounds like sort of that it's simple or negative. Like I feel like I write largely to tell stories, not, I was going to say just to tell stories, but to tell stories, not necessarily to spark some specific change. And I'm wondering what your hope is with this book.
So for me, my writing is connected to my life mission. I feel like as a doctor, I can, be involved in the care of one person at a time, maybe one family, maybe one community. But through writing, you can reach so many more people around the globe. So in that way, I feel like it's connected to my mission to be part of healing work on an individual level, and then around these larger issues we've already touched on, which is dismantling structural violence in general, whether it's misogyny, sexism, homophobia. That's what I'm here to do, and that's why I write. And if I couldn't do that, no, there is no I couldn't do that. So it just has to be.
Yeah, it's fine. You're just finding different avenues to do it. And yeah, and I think I see that in these stories. And I feel very strongly about the power of story to prompt change in ways that academic research does not, at least not in the same time frame. So yeah, thank you for that. And thank you for making us all think. I am sort of deeply appreciative of it, and will carry these stories with me for sure. Which is a good segue, I guess, to we have a couple of questions. The first one, which has one vote for it, which is the most votes that a question has. So I'm going to ask it first. Is this to you? I was so moved by the statement, quote, "If I were to evolve, I would have to regard his brokenness genuinely and my own tenderly." I think that's about is that about the Eric patient, maybe?
I believe so. I think
yeah. I love this line. As a healthcare provider myself, I just find this process to be so dynamic and difficult. To be tender to ourselves in the face of the challenge of being so present to our patients. Mm-hmm. How have you committed to be more tender to yourself? Advice welcome.
Oh my God. Well, and part of that is illustrated in that discussion where I believe in radical honesty. And people like Tara Brach talks about this: radical acceptance, radical honesty. So that was a moment where I called myself out. Well, I acknowledged what I was feeling, and my anger and disgust was valid. And I also called myself out on my behavior. And then I had to deal with that. Part of it was taking corrective action in the moment. But then clearly my meditating on it later, which is why I wrote about it. And I try to bring that, I'm a human being, not perfect. So I try to bring that to everything I do, recognizing how I feel, sitting with it, working through it, being totally honest about it. And then when I'm able to take action.
Did you call yourself out in the moment?
Oh, yes.
Yeah, you recognized it in the moment.
In my head.
Yeah, in your head. Nobody needs to hear that right then. Like, you have to get the guy to surgery. But
right.
Yeah.
I try to do that in other aspects of my life as well. And I feel like that's the only way that I'm going to grow and evolve. So those are my, that's a practice I believe in.
Another question, a life working in the ER has brought you insight and empathy, but I'm sure that didn't happen overnight. And these are they're all, to a theme. What advice would you have for young people just starting out, looking for some direction on how to foster compassion and connect with patients?
Young people
I guess young people who are maybe starting out in medicine.
Right. And, it did happen over time, but it started in my youth. So I don't think I'm unusual. I feel like we've all, at least 99% of humans, probably all, and maybe some just don't recognize the trauma they've experienced, but most people have had challenges and difficulties. I mean, that's part of the deal of being a human being and being alive. So I feel that connecting to our own experience, working through it and healing is I almost want to say the first steps, but if they're not the first, critical steps towards empathy, because, let's be honest, if a person doesn't understand themselves, it's really difficult to understand another person. It just is. So I think that process starts from within and then expands. outward.
Mm-hmm.
So that's what I would encourage. And then just fostering an openness. We're all going to have ideas. I mean, even in that story, I had my preconceived notions. And my ideas about his behavior are right, but they're not necessarily relevant. So even just making that switch of understanding, I may have these ideas and I may be wrong, and I'm open to understanding whatever this moment has to offer. I would say that's another critical piece, because it happens to me in the ER all the time. I may think something and turns out it's not the case, and that's okay.
Do you try to bring that to trainees? I don't know if you're working with trainees right now, but
right now, I mean, it's mainly community, but we do have some residents coming through always.
Mm-hmm.
For me, that's an important teaching point. Always. So, yeah.
I think there's an interesting sort of ideas in medicine about, to what extent you can teach empathy versus this is something that is just inherent in an individual. I don't know if that's something that you kind of see in these people who come through. Like, can you teach them to be more empathic, or I guess at least to act more empathic? I don't know.
Yeah, I mean, I suppose you can teach people to have manners. I mean, you can teach people.
Right. It's not the same thing as empathy, but it might feel similarly on the outside.
And that's at another area that I'm really passionate when we talk about inequities and disparity. If we have a system where certain people aren't screened out, like if we had in medicine more women, more people of color, more people from poor backgrounds, more people with different levels of physical ability. Like if these people were not preferentially screened out, then I believe we would have more compassionate providers. Because you're right, you can't teach it. And we've screened against it in ways that are problematic. Got to do something about that. And studies show that when you have providers from more diverse background, patients do get better care. And that should mean something to us.
Yeah. I mean, we pretend like we react to evidence in so many different arenas, but in that particular evidence, we just sort of say like, and
interesting.
Yeah. Oh, that is interesting. I see how that could make sense. And then move on, or say things like, we really need more people in this, position. Like, okay, but we're weeding them out in the pipeline. Like that doesn't make any sense. Somebody else wanted to know, given that you're both busy professionals in healthcare, can you explain how you find the time to write? Go ahead.
So, I don't know, like just the rest of my life has fallen apart. Like, like a tornado was blown up in my condo. So, that's just kind of it. Something's got to give. Right now, you just prioritize, make choices. I didn't make dinner. I bought a salad. Sorry, it's just real. I'm going to be honest.
I mean, you could have done worse. You bought a salad. Like, come on.
There was lamb on it.
Okay, never mind. I take it back.
So it's just this balancing act of, I got to do my shifts. I want to do this writing and the events, and I love connecting with people, and I can't wait till it's in person again. And that just lights me up and rejuvenates me. And my work it's not a job, it's a mission. So I will answer the call of the mission. And then you're right, or the voice in my head is right. I have to somehow make this sustainable, and I'll have to figure that out in the months to come.
Yeah. I mean, some things will fall away, and you didn't like them that much, I guess, like maybe making dinner. I'm not really sure. But it sounds like one of the things you're saying is that this feeds you in many ways, and it's a way to process, and if you didn't like to do it, you probably wouldn't have done it. It's like people don't like to do, they ultimately don't do things that they don't like to do.
Oh, you know what? And speaking of, how adversity can have opportunity. Everything about this pandemic is, terrible for so many reasons. Having to do things virtually, I mean, I will say the one thing I'm appreciating about it is it has freed up time that wouldn't otherwise be there. I mean, it makes it I can more easily log on. It saves time for travel. I also really like the idea that people anywhere can log on more easily. I mean, it's an equalizer in that way. Maybe people couldn't afford to get a babysitter or take off work earlier, but now they can just log in. That does make me happy that there are some small, positive, very small, but positive aspects of this.
No, I agree. I think that we are managing to find ways to at least feel somewhat interconnected in an entirely isolating time, thanks to these many devices that we have, and allow us to take some other time to do things that are important to us. Somebody else wants to ask, sort of broadly, what advice would you have for someone aspiring to become a doctor? I can jump on that question as well. To become a doctor or not? Do you tell them to do something else? I don't know. Did you ever have moments where, I mean, I feel like for a lot of people who end up doing doctoring plus, I guess, there are moments where people think, maybe this wasn't the right call. I don't know if you've had moments like that. Go ahead.
I have, I feel like my path needs to evolve. It certainly can't be the only thing I do. But I would say, and I am getting that question a lot, whether it's on formats like this or Instagram or radio. And what I keep saying is that loving this work is not going to be enough. It's just not going to be enough. I mean, there's so much crap that comes along with it that literally stands in the way, obstructs your ability to help people. Literally, like the reason we're here to do this, there's so much that stands in the way of it, that loving this work isn't enough. I feel like it has to be a mission and a calling, because if it's a mission and a calling, then it will be enough. It will be enough to come back day after day. It will be enough to take the crap and try and make positive change within the institution. And so if you're doing it for mission, then that is fantastic and we need you. And if you're not, I don't good luck.
Best of luck.
Yeah.
No, I think that's so the idea of like job versus calling in medicine, I think is really interesting. And I think that there's a lot of, burden's not the right word, but there's a high bar for people saying, this needs to be a calling, and like, can you do it and feel fulfilled and have it just be a job? And I think the point you make that you're just going to get beaten down by the fact that there's just too much. And for you guys in the emergency department particularly, I can't even imagine. At least my patients, there's like a finite number of them, and I know they're all sick. So I totally hear that.
And when I say that, though, I actually am a little hopeful. I mean, there are. I wrote a book about it. There are times when.
I mean, you say you're hopeful, yeah.
We have to be broken down. This healthcare system is not working. We've not yet hit bottom, but we're on our way. And sometimes, unfortunately, that has to happen before those of us who care and are willing to act have enough numbers to make a change. And I do believe that ultimately it will be rebuilt better. I mean, I believe that, which is the only reason why it's not the only reason. I mean, the main reason is so that they can help people who are falling through the cracks as we hit bottom. But I believe that it will be improved, that we can do it ultimately.
And if anything comes of the fact that so much is destroyed right now, I mean, it is that recognition, it is that fact that it's impossible to ignore that things are broken, and hopefully, and that we're all interconnected in a way that like we didn't recognize. The little, the careless thing I do might hurt somebody else, and like that's something that is so powerful too.
Exactly, it's so true. Our interconnectedness, the brokenness, and then rebuilding better, like that. What I love to refer to, the Japanese art of kintsukuroi, where a piece of pottery is broken and then it's remade by an amalgam of precious metals, so that each crack is highlighted by gold or platinum, because it is that much more beautiful in the rebuilding.
I mean, that couldn't come at us for more apropos time for everyone we are all in this time of brokenness. Yes, finding connection on Zoom, but like really it's not okay. And we know it's not okay. And I love that image to bring us forward. I'll end with just one more question from you from Books and Books, which is just to say, what's next? Another book, other thoughts?
We will see. I'm a little superstitious. I hate speaking about something until I know it is actually happening. But do I have other books and projects in mind? Yes, because there is a next. This is not where it starts and stops. Definitely not. So more to come, and I'll talk about it as it's happening.
Excellent. Well, I'm sure we all look forward to it. So thank you.
Thank you. Thank you so much. It was so fun hanging out with you.
So I want to thank you both. That was a fascinating conversation. And Michele, you have something called the audacity of hope. And we love that around here. So to find the beauty in breaking is really something commendable. Thank you for sharing your work with us, your time with us tonight. We really appreciate it. Everyone, please order this book. You can do it by just pressing on the green button at the bottom of the screen. I thank you so much for joining us. I hope that you will stay safe and well, and that we will see each other in real life very, very soon. Thank you.
Thank you.
Thank you.